we are going to have a panel discussion, which will be led by cardiologist Dr. Prabhakar, very dynamic individual. And the panelists are Dr. Mala, Dr. T.R.Muralidharan, Dr. T.B.UmaDevi, and Dr. Vijay Chakravarthy. I think the moderator will introduce the panelists also, and he will proceed with the panel. Perioperative assessment and management of cardiovascular disease in non-cardiac surgery. Over to the moderator, Dr. Prabhakar.
Am I audible? Yeah. Thank you, Dr. Shanmugam sir, for the introduction. And thanks, Dr. Chandrasekhar, for giving a very important topic. But unfortunately, to stand and assess perioperative cardiac assessment just before lunch is going to be a little difficult. We'll try to do how much justice we can do. Now, basically, perioperative MACE is important. It happens in about 5% of patients undergoing non-emergent cardiac surgery, which is going to be 1 in 20, which technically means that it is going to be more or less there every other day in your operative practice. So you have to be a little careful. And to unveil the crystal ball, we have 4 people: Dr. Muralidharan, Professor of Cardiology, and Dr. Mala, anesthetist, all professors here, Dr. UmaDevi, physician, professor, and Dr. Vijay Chakravarthy, who is a critical care consultant. He's also a physician and a critical care consultant. So we have 4 people who are trying to unravel it. So what I will try to do is give you a couple of cases, and we will discuss what they practice and are they practicing it correctly. The first case I'll give you is a 50-year-old hypertensive diabetic on OHA for abdominal hysterectomy, which is what commonly the OGs give you. No previous heart disease, blood pressure 150/90, hemoglobin 11.5, creatinine 1.1, HbA1c well controlled 6.9. Case is sent to the physician and the anesthesiologist. Now, first they meet the anesthetist, Dr. Mala. Dr. Mala, what do you think about this case? Do you want anything else further? ECG is normal.
Good afternoon, everybody.
We'll keep it a little
Thanks
short.
for the opportunity given. I'll go through the risk factors fast. So, putting in the clinical risk predictor list, she has anemia, diabetes, hypertension, which is in stage 1, probably 150/90, as given by sir. And her functional status not mentioned. Probably she may be having more than 4 meds. Probably she has no cardiac disease. So I assume that it is more than 4 meds. Or it may be less also, we have to evaluate. And she comes in the intermediate risk as far as the predictors are concerned. So considering the risk, she has to undergo intracavitary surgery. It is abdominal hysterectomy. So I'll put her in the risk group of more than 3% as far as surgical risk for MACE is concerned. So apart from the routine investigations, I'll ask for the 12-lead ECG, then echo. Then for the control of hypertension and also for optimization of glycemic status, she's on OHA and she has to plan for major abdominal surgery. And also for the improvement of her anemic status, initially I'll go for physician referral, and I'll get the physician optimizing the patient. Over to
your ASA risk scoring in this case is supposedly? So patient has got a mild systemic disease without any significant problem. So you have a well-controlled diabetes, hypertension, and an intermediate risk surgery. So you don't expect much of a problem in this particular case. So I have a simple algorithm for people who can do it. This is called the Yampel algorithm for anesthetic assessment. Have you heard of this? This is called the Yampel algorithm, which might be useful for all of you practically. Y stands for why the surgery, which is what the anesthetist asks. Is it really essential? This is what most of the time anesthetists ask you. Your anesthetic history, medication history, your past medical history, which is going to be system-wise, the last meal and examination. How do you like this? I thought it's a very simple algorithm.
Yes,
so I thought for a non-anesthetist, if you look at it, you will know what the anesthetist is looking for. So with that, we'll go to...
the first point is why the surgery?
No,
that I have
just...
no control. Then anesthetic history. Anesthetic history, I'll go through a detailed history. Then any previous history of anesthesia, any allergies.
Madam, you have answered. Don't worry, you have answered all these questions already. Okay. So I'm just giving you an algorithm. This is just making life simple. Dr. UmaDevi, what is your assessment? What is your take on the case? She has referred the case to you for assessment.
Yes. Sir. So first, as physicians, good afternoon to all of you anyway. First, as physician, so history taking becomes very important here. Now, it has been referred as hypertensive diabetic for OHA for on OHAs. So first, the detailed history taking. Now, we want to know the functional assessment. That can be taken only by the history taking. Then diabetic history also is very important because is there any micro or macrovascular complications and what is the present status? Then seeing the, like I'll come to BP last, hemoglobin was 11.5. What now during this, when the topic was given to me, I went in detail and I found that now ideally hemoglobin should be maintained more than 13 gram per TL. Now what they say is in a surgery where you expect a blood loss of more than 500 ml, ideal to keep hemoglobin above 13. And maybe in Indian setup, maybe more than 12 for a female is okay. So I will evaluate for anemia, most common now because of hysterectomy, iron deficiency. So if it is an elective, so we can either plan for oral or IV iron sucrose. Then HbA1c 6.9. So definitely more of optimal control is required. Then now during surgery, what is there are two ways. One, we can ask them to stop OHA on the day of surgery. They can undergo, they can plan for surgery, and post-op either insulin or OHA can be restarted. But anesthetists prefer insulin, so I'll start human actrapid, short-acting insulin, monitor the glucose level. Ideally, it should be more than 180 milligram per DL, means less than 180. So more worrisome is hypoglycemia, which we don't want to occur when the patient is in intra-op and post-op period.
We agree with your part. We'll restrict to cardiac aspect. Diabetes, if you go, we are adding some more time because everybody is hungry. So we'll restrict to cardiac assessment.
Yes. Yes, sir. Yes, sir. Yes. Sir.
So do you send these kind of patients to the cardiologist?
BP 150, 90.
We'll come to the blood pressure separately. At this point, do you wish to send to a cardiologist? Which cases do you, both of you, prefer to send to it?
Because I want to know the...
Just because he's here, you don't have to refer.
Sir, I'll see.
Which is what happens in most of the corporate hospitals.
Sir, I'll see the ECG first. If there is any T wave inversion or if there is any pointers for ischemia, definitely I'll like to know the LV function.
Let's say non-specific T wave changes in bleed 3 AVF. This is what most of the ECG
I want to know the LV functions, sir. Diabetes may be having diastolic dysfunction, so the risk stratification is important.
So I think we'll send it to Dr. Murali and ask what his opinion is at this point of time.
I think thorough discussion has been made on this. So 2 ways to look at it. Like you may help me by giving some more detail. But what we are aiming for, the whole idea is to prevent event. Want to prevent MACE. Cerebrovascular secondary maybe. The coronary event you want to think. So here you are seeing a milieu for a coronary event. Like patient diabetic, hypertensive, we know the lipid status. And we are going to go into the details of it later. But our aim will be, are we going to clear the patient for surgery? Can we have some scoring pattern? That's what I would like to look for. Now we have all the data. Madam has given how to manage diabetes, hypertension, we'll wait for it. In this situation, I would like to think of some of the standard scores that can be imparted among us, among all our colleagues to go in. One is the revised cardiac risk index. That's what we regularly follow in my practice. You can elaborate. It's your side.
No. Basically, I think whenever we do a cardiac assessment, this is probably the most validated score. What Madam said, I will come to that in the next slide and show you. She made 2 additional points about anemia. I'll come to that. But the most standardized scoring is just these points. These points, what is the type of surgery? High risk surgery. High risk surgery is basically any kind of vascular surgery. Low risk surgery is anything like an endoscopic procedure or a cataract, breast surgery, or any daycare surgery. Possibly is a low risk surgery. Anything else is intermediate, like you open the abdomen, open the thorax, or open head and neck surgery. Anything else, most of the other surgeries are intermediate risk surgeries. So high risk surgery is one, history of ischemic heart disease, congestive cardiac failure, and cerebrovascular disease. So these are 3 important risk factors. Diabetic already on insulin is a risk factor. The important other thing is creatinine more than 2. So you have 1, 2, 3, 4, 5, 6. You have 6 factors, and as the risk factors increase, the risk for a perioperative major cardiac event increases. So 0 seems to be good, 1 seems to be good, but when it goes more than 1, it is always a risk factor. So you have to be careful. So I think in your clinical practice, when you start looking at it, please look at these risk factors. There are several other risk factors that are available, like the cardiovascular risk index. And apart from this, there is another score. But today what has happened is this RCRA also, even if you don't have the creatinine or diabetic on insulin, if you remove these two also, just look at these 4 factors. The remaining 4 factors: type of surgery, history of ischemic heart disease, congestive cardiac failure, and cerebrovascular accident. They are also equally predictive. So please get those 4 into the history. So you must look at these 4. And as this increases, the risk increases. The other point she made about anemia and this thing is there in another score called the cardiovascular risk index, CVRA, or the AUB HAS index, which includes 2 other points: age more than 75. And they also include hemoglobin less than 12 standard. So these 2 are there. But having said that, it doesn't say anything about preoperative increasing the hemoglobin, because there are orthopedic surgeries which have clearly shown that keeping a hemoglobin of 8 or 10 or 11, the perioperative mortality is the same. So it doesn't change. So acutely increasing the hemoglobin beyond 8 is a little questionable. So we're not very sure about that. But there are several other risk factors. But what I thought is we will stick to one particular score. All of us will try to remember the RCRI, which practically is going to be very useful in all of us. So TRM has already given his opinion and clearly said this is what happens. Now I'll come to Dr. Mala again, or Dr. Uma. One of you can answer this. Now, this is what you were talking about, the blood pressure of 150 by 90. Do you think it's acceptable? Dr. Uma can go ahead.
Sir, now ideally diabetic and hypertensive, I would prefer less than 130/80. But now this patient is going to go for surgery. So I think 140/90 will be acceptable, sir. And surgery, metoprolol can be continued, but telmisartan will have to be stopped 24 hours before surgery. Now over to Mala.
So many patients, we do take up 140 to 150/90. And the main concern intraoperative will be to maintain the map according to the pre-op measurements. That is the BP that the patient has been used to for quite some time. So depending on the BP, we maintain the map. So the outcome is also good, sir. That is the practical thing that we have observed. There is no need to restrict to 130/80 and all. We don't bring it down. 140/90 we give assessment.
Beautiful
and
point.
We go ahead with the surgery.
Excellent point. Stating that 150/90, don't be scared. Don't go for an ideal blood pressure at that point. Dr. Murali, your point about this.
Same thing. Like trying to make a person normal is not the aim of the thing, because we know not only by practice but by strong data that doesn't make an impact. Whereas by making him hypertensive, going to have a massive impact on the outcome of the surgery or the anesthesia. That's the most important. So given a choice, I don't want to stop things. But here I would like to open this discussion. Like it's a fear. I do see with my colleagues also anesthesia, like AC and ARB in the perioperative period. Highly sensitive, anesthesiologist is highly sensitive with these 2 things rather than other antihypertensives. Maybe a few opinions, but little going deviate in the topic. But our aim or the message I would like to convey will be mild to moderate. I would give a BP 180 and diastolic given 100 to 110. Most of the time doesn't affect the outcome by data, by practice. So aiming for that to bring it down is should not be the idea of physician or cardiologist, anesthesiologist. We can take up. But most important thing, as Madam said, perioperative, intraoperative, maintain the mean arterial pressure, preventing hypertension, avoiding the low perfusion state is most important.
As far as ARB and ACE inhibitors are concerned, and if the patient is going to have lots of blood loss during surgery, or if we resort to some regional anesthetic procedure like spinal or epidural, it is going to be additive for hypotension. So to prevent all those intra-op, thinking them in mind, we want to cut short ACE inhibitors and ARB 24 hours prior to surgery, and restart them once the patient starts gaining back the original BP.
That's a little bit of controversy that you have clearly said, but what she says is very practical, because they say if it is on the day of the surgery, you need not always, but you can withhold the ACE inhibitor and ARB on the day of the surgery. And because if the hypotension happens, it is going to require multiple inotropic supports up to vasopressin. That is clearly mentioned. So be more careful. But actually between hypertension and hypotension, you look at this BP and perioperative mortality, blood pressure less than 119/63. Basically, hypotension pre-op is more dangerous than hypertension pre-op. Please remember that. Hypertension pre-op can be very high and it is not a problem. Even a blood pressure up to 180, 110, you need not acutely bring down the blood pressure pre-op. This is for Dr. UmaDevi, who wanted a blood pressure 130 or 140. So even up to 180, 110, you're justified. And never start a drug on the day of surgery. That's very, very important. Just before wheeling in, they call you and say, sir, BP is 160, 100. What should you do? Our knee-jerk reaction is give a calcium channel blocker. That is absolutely dangerous because these calcium channel blockers will actually increase the bleeding. And intraoperative, when the hypotension happens, that's when the drug acts and all kinds of problems. So on the day of surgery, you don't give the drugs. Up to 180, 110, you can take up the patient for surgery. Remember, this is guideline directed and it is not a problem. Beta blockers, I think she had clearly said continue. All of us agree that beta blockers should be continued, but don't start 24 hours prior to that. If you're going to start a beta blocker, start preferably at least 1 week prior to it. Who are the patients you want to start? The high risk patients. When the RCRI is more than 2, these patients are protected by beta blockers. So you can start beta blockers. So when you see preoperatively, start them at the outpatient. So by the time they come in, they're at least more than 24 hours following on the beta blockers. So beta blockers are beneficial. Any other antihypertensive drugs you want to talk about? You already mentioned about ARB. Any other drugs you want to talk about, Murli?
2 points only about the POISE trial also. POISE trial, though very well done, and it was against using beta blocker. The dose was very high, 200 milligram metoprolol and all. That's what we don't use it nowadays. That's our problem. Other thing is the other trial which tried, probably it's for I'm not able to recall the name. Clonidine was tried, which also negative only. It didn't show any superiority. So currently, if you ask, I prefer beta blocker in our practice, and as you are rightly pointed out, we would like to, as you said, rightly start it much early, not on the day of.
So if you are giving a diuretic, remember this point also. You stop the diuretic on the day of the surgery. Be careful, look at the hemodynamics and start the diuretics. That's the only other additional point. And never start an alpha centrally acting agonist also at that point. Be careful. The point about intraoperative blood pressure you clearly made, but the one single factor is a mean arterial pressure less than 55, even for a transient time, is dangerous. MAP less than 55 can be dangerous intraoperatively. Be careful. And like you clearly said, there is a clear case for maintaining 10% around the preoperative blood pressure. That is a concept that seems to be working. Yeah, 25%
of baseline.
So that is clearly understood. So try to maintain what your previous pressure was, and that is quite acceptable. Vijay, what's your thought? When do you see post-operative hypertension? When do you start intervening? Vijay is feeling bored, sitting there between 3 people.
No, definitely not. It's a very good talk going on. So post-operative hypertension, this patient is a chronic hypertensive patient. So I'm definitely expecting a post-operative hypertension for this patient. We call acute post-operative hypertension if the patient is having a blood pressure of more than 180 by 100. But he is already on metoprolol. She is already on metoprolol and telmisartan. Now there is no particular target in the post-operative period. There is no systolic target. There is no diastolic target. There is no MAP target. Only thing I have to see is watch for the hypotension, which is very bad, and the baseline pre-op blood pressure is very important. So my target in the ICU or in the ward post-operatively is going to be the 150 by 90 plus or minus 10%. That is going to be the target for me. And the problems with the antihypertensives I might be seeing is the beta blockers. Again, it might mask the hypoglycemias and the sympathetic. During the surgery, they have completely taken off the sympathetic drive, so that is going to be there for some more time. And first, the patient might be having a hypertension like around 180, 190 immediately post-operative. There are several causes for that. Patient factors, yes, he might have skipped the medications, or the sisters might have forgotten the medication. Then the second thing is that pain, bladder retention, all these things should be considered. Inadequate anesthesia, inadequate all these reversals, everything should be considered for the patient before directly jumping into the blood pressure antihypertensive medications. So all these things, and sometimes the drugs, vasoconstrictor, what we use, fluid, what we have given, they would have given 2 liters or 2.5 liters of fluid, or some FFPs, whatever thing they would have transfused. So all these things have been taken to the consideration to maintain the blood pressure around 150, somewhere between 140 to 160. And
advantage of having a physician intensivist is this. He thinks beyond that intensivist point of view and goes beyond. It's, I think, perfectly correct. Look at the pain management, which is absolutely important, because that sympathetic drive is the one that precipitates the cardiac events. So that pain management post-operatively
Not only
becomes
that,
important.
the sisters might be doing a suction post-operatively, some suction, someone would have been palpating the abdomen or something. So everything will stimulate their high sympathetic system, and that is going to cause the hypertension for.
So a little addition. Come again, sir? Yes.
I told bladder distension.
Right.
We
So
have to take
post-operative hypertension, Vijay was liberal at 150/90, but don't worry, up to 180. It is up to 180. You actually should treat it if there are symptoms of either cerebral myocardial ischemia, cardiac failure, or dissection. Otherwise, a blood pressure of up to 180 initially in the post-operative period is still acceptable. You can be a little more liberal with your patients
No,
henceforth.
I'm just telling the
Agree.
pre-operative
Now,
thing.
now
we
we're
can-
coming to that. And when you're trying to reduce the blood pressure, don't reduce it too much, more than 25%. So don't try to reduce it more than 20%. That's also important. Some amount of asymptomatic hypertension is permissible always within the first 3 to 5 days. Don't be strict because the hemodynamics are variable depending on the several factors that he said. And if it's more than 180, probably the best control is the IV drugs. Because you can stop it anytime you want, because you don't know what's going to happen at that point. So IV drugs are going to be very, very useful. So I think we had learned a lot of new things. You can be very liberal in your blood pressure management is the most important thing that we discussed. And the second important thing is use a simple risk scoring like the RCRA risk scoring for preoperative risk assessment. Now, this case is going to be for Dr. Muralidharan with a very simple question. Diabetic hypertensive post CABG on aspirin comes for fitness for cataract surgery. Specific question. You're not going beyond that. What is the role of stopping aspirin in cataract surgery, which comes to all of us? All physicians see these cases. Do you need to stop aspirin?
Simple answer, no need.
No. I think that's very, very important. It's not only aspirin. Perioperative events, when you look at patient on no aspirin use, discontinued or continued use, in fact, the patients who were not on aspirin had more side effects in a large scale study, which is about 10,000 patients data. So it is clearly shown that you need not stop aspirin. Please tell all the ophthalmologists, none of the ophthalmologists believe me that, but I don't know what. So I write that you need not stop aspirin, but if you're scared, you can stop aspirin. That's what I write in my preoperative assessment. Seriously, I write that and send it across. Similarly, with warfarin, there is enough data to say that for a cataract surgery, you may not actually stop the warfarin. There is data to say that anticoagulation need not be stopped because that's actually a bloodless surgery. Nothing happens in that. So you have to be a little careful and start doing that. What about dental extraction?
Same thing. For aspirin, nowadays we don't bother, but dual antiplator, we get worried. Other anticoagulants, of course, we are really worried, like warfarin or Novax, but that's a little away. Maybe a short term. In fact, we are more comfortable with Novax off late in this situation. We just keep one dose and get it done also most of the
Yes, ma'am. The anesthetist added.
Cataract surgery, you're saying no need to stop aspirin. But for cataract surgery, we resort to blocks. So if there happens to be some kind of mishap, intravascular or some kind of mishap, will this aspirin continuation will give trouble?
All these cases had.
On
This
that
is
worry
data.
only, sometimes
Agreed.
we stop.
But how
but,
often have you seen?
it's better to continue.
How often have we seen data clearly shows that it doesn't happen? We are talking about the ocular hemorrhage, the medical events, everything seems to be clearly showing that you need not be worried about it. This is what they keep saying. This is what the problem is. Exactly same question keeps
Lot of
cropping up.
blocks we give.
So nothing happens. And nowadays, all your blocks, you use an ultrasound and give a block. So you know where the vessel is. Retrobulbar you can't. Fine. So basically, it is clearly mentioned for a cataract
But
surgery.
it doesn't happen. Effects are negligible, but
Have you seen one case so far?
no, I've not,
nothing.
I've given blocks, but I've not seen one.
Right. Same thing for dental extraction or minor oral surgery also. Even dual antiplatelet therapy can be continued. Remember one thing, all these can be stopped by local measures. So no major events happened. So like Murli clearly said, remember for dental and cataract, you don't have to worry about it. And this patient, when they was wheeled into theater, developed an irregular pulse and the anesthetist was called and found out that there is an atrial fibrillation. So what do you do?
First of all, I will see the ECG pattern, then see the hemodynamic status. If she is stable or not. If it is something related to ventricular event, if it is going into arrest scenario, immediately start CPR and the rest of the
Patient is
thing.
comfortable.
And if it is
No, patient is comfortable lying down. They
Comfortable.
found irregular pulse. Somebody took an ECG and you said atrial fibrillation. So what do you want to do?
okay, if it is atrial fibrillation, what is at hand? If the patient is stable, I will observe. I will not intervene immediately. I will observe. If the patient is stable, I will observe and see whether she is comfortable. Is there anything that is precipitating event? Obviously, we have all the pre-op
Only one
investigations
question for
ready.
you. Only one question for you. You
What?
do the surgery or postpone the surgery?
we will postpone the surgery.
Clear.
Definitely, we have
That's
to
all.
observe and
So
postpone.
obviously it goes to the cardiologist next. I'll skip
Yes,
Dr.
yes,
Uma.
I'll call the
You want to say
cardiologist.
something?
I'll observe. In the meanwhile, I'll get the
Stop.
investigations ready.
So as anesthetist, you
Mainly
stop the surgery.
electrolytes,
The message here is clear. You have a newly detected atrial fibrillation for an elective surgery. What she said is the single message. Newly detected atrial fibrillation prior to surgery, you stop. Till you evaluate and find out what's wrong, you don't send him for surgery. So Dr. Mala, Dr. Uma, you want to add something, or we'll skip to Murli straight away? So Murli, go ahead. So what do you want to do in atrial fibrillation? Newly detected.
The first point is the problem in this situation is not the surgery on the day, rather how the patient going to perform over the next several months or several years. So per se, as surgery per se, he will be fit. Even a new atrial fibrillation, even if totally stable, as we say, it will be fit. Only thing is that we will be monitoring a perioperative any increased critical response, whether we need to do a rate control measure or we have to go for cardiac. That's one thing. But a stable patient, atrial fibrillation, control rate, hemodynamics are stable. That's not a major risk. But we know from that moment, this patient goes to a different fold. Like we always worried about coronary artery disease, but we worry about heart failure more than coronary artery disease situation. Number one, this type of patient are more prone for heart failure events. Number one. Number two, more risk of thromboembolic event. Even the mortality and morbidity goes up, not in this period, but going to go up and up and up in the next several months. So perioperative atrial fibrillation to be watched, post-operative you have to watch, and obviously you said this patient initially is normal. So I presume that is a paroxysmal atrial fibrillation. So I may have to start complete different algorithm for atrial fibrillation management.
So basically,
but for surgery, go ahead.
So actually what you say is you, for an elective surgery, stop the surgery, assess for the usual things like thyroid, the LV function, rheumatic heart disease, electrolytes and other things, and then plan for surgery. There's a very interesting data that came up about 1-2 months ago in JAC, which actually says patients on atrial fibrillation, there is an increased mortality, there is an increased heart failure and stroke, but incidence of myocardial infarction is less if you have atrial fibrillation. The reason they say is very simple. Most of these patients are on anticoagulation, so that seems to be protecting these patients. So any atrial fibrillation intraoperatively, like Madam said, she actually came into the intraoperative part and overlapped and gave the answer to what I wanted. Intraoperative atrial fibrillation, depending on the hemodynamic status, if your heart rate is maintained less than 110, possibly because the beta blockers, you really don't have to worry. But if it is more than hemodynamic compromise is there, or there is a problem, you have to treat it. And if there is a compromise, you either cardiovert or amiodarone them. Otherwise, you can just go for a rate control and accept this. And post-operative atrial fibrillation, I think Vijay must be saying, due to shortage of time, I will skip your question and just give you the answer. It happens in the first 4 days usually. And usually maximum the first 24 hours, but it happens in the first 4 days. And unless the same criteria is applied to postoperative atrial fibrillation, the intraoperative atrial fibrillation, unless there is hemodynamic compromise, stay cool, take your time and treat these patients. Don't panic. You don't have to really panic on these patients. But when do you anticoagulate these patients? Murli, probably same is there.
Okay. Any first time atrial fibrillation or a paroxysmal in this type of situation.
Just a post-operative. If you're pre-operative or something, Chakravarthy score, yes, fine. But post-operative atrial fibrillation, first time.
Of course, you have to anticoagulate, but the risk of thromboembolism going to go up.
Long-term anticoagulation. Huh? Do they need long-term anticoagulation?
Long-term going to be decided by his overall profile. That's why I said no. Take him as an AFib patient from that moment. Proximal atrial fib. It is going to be intraoperative, post-operative. We are going to the repeater proximal atrial fibrillation. So the whole idea is going to be what is the risk of thromboembolism in this? Is a female patient. We have to go for a Chakravarthy score. We are going to score it according to that. Then decide. As you said, we have done the assessment already. We have done every assessment of this patient already. So we can easily place the patient, what place the state, plan for the anticoagulation long term if it is needed.
So basically you go by the Chakravarthy score for most of these people. But any atrial fibrillation more than 48 hours or recurrent atrial fibrillation, at least 30 days of anticoagulation, even if nothing is there. So remember this part extra. This is additional to what he says. More than 48 hours of atrial fibrillation or recurrent atrial fibrillation, you have to treat it. I don't think we'll have time to discuss this. If time permits, probably if Chandrasekhar gives me time, we'll talk about anticoagulation, or just one word on the difference between NOACs and warfarin preoperatively. Any surgery, when you want to send them, patient is on warfarin and
again, it comes to whether it's going to be emergency surgery or elective. Shall we discuss both?
Just 2 lines about when to stop, when to bridge,
big problem
whether to bridge or not to bridge.
That's the biggest problem we face. Like if the emergency surgery, patient will anticoagulate, either vitamin K antagonist or NOVAX. the risk of bleeding going to be quite high. How to reverse it is a question. Patient with a prosthetic valve, mitral valve sitting in, we want to give vitamin K. That's one of the common things people do. I don't recommend it. You may get a ball of thrombus on the valve, prosthetic valve dysfunction. So we may have to think something else. Novak, same thing, but we have excellent antidote now. Idarucizumab and antaxanol, all four available now in West. In India, only idarucizumab, Paxlovid only available. So you can reverse your time. Elective, it is much convenient. So you assess the patient, when was the last dose taken. For the available, only 3 are available in India. Dabigatran, Rivaroxaban and Apixaban. You can, depending on the type of thing, when was the last dose, type of surgery, you can stop either just 1 dose to 1 day to 2 days and restart also by skipping 1 dose, 1 day or 2 days. So much comfortable. Elegant algorithm are freely available, so we can follow that.
Sir, if it is very urgent, emergent procedure, patient is on warfarin, lands up in emergency, taken up for surgery. So in that situation, what is the option?
Tough question. This is the toughest question we have. You have to go ahead. You have to go ahead. I'll tell you very simple algorithm. Like
FFP?
Generally, when we talk with the team, surgical team and anesthesia team, we make a quick team approach. We discuss. We are going to weigh it's a high risk situation. We weigh the risk with and without surgery. Maybe I can quote an example. One of our patients years ago, patient anti-wall MI, 4th day. It was thrombolytic time, primary period yet to enter. Patient thrombolized, but still there is LV dysfunction. He has got a mesenteric angle. The anesthesia team want to say we cannot do surgery. Just 4 days of MI. So the question in the discussion, only one question I asked. I asked the surgeon, sir, what do you think the outcome without surgery? He said 100% death. I said, then go ahead and operate. Well, even the 95% death, even 95% chance of dying with recent anti-wall MI, still there's a 5% chance. We all know mesenteric ischemia and gangrene. The death is only 100%. He said, please, you have to operate.
So emergency surgery is a different ballgame. So you answered something else, which is coming in the final algorithm. So from what Dr. Murali said, there are two kinds of anticoagulation. One is the warfarin group, warfarin acetron, and second is the newer anticoagulation, the dabigatran, apixaban, and rivaroxaban. Now, these 3 drugs, within about 24 to 48 hours, the effect is totally gone. So you can plan for surgery, no bridging is required. Now, the current trend to use warfarin is you stop warfarin for 3 days, let the INR drop less than 1.5, you can take them up for surgery. Less than 1.5, you can take them up for surgery. But when it drops to 1.5, and if you're delaying the surgery for maybe for your thyroid is high or your sugars are not controlled or some other issues, then you have to bridge them with anticoagulation. So you have to give them parenteral anticoagulation. And once you restart, how soon do you restart after surgery? On the day of surgery and next day you can start, because warfarin is going to take 3 days to act. So you can start on the same day, and none of the surgeons will let you do it. Don't bother, just give, because it's not going to work. It's going to take 3 days. And if beyond 48 hours, if there is going to be otherwise no other issues, you can actually bridge it post-operatively for about 3-4 days.
How early you can start, sir, warfarin?
Same day you can start, because it doesn't act.
My doubt is if there are drains which are still losing and no need to.
Warfarin takes 3-4 days to act.
The losses are going to be replaced. We are going to maintain hematocrit.
No, madam. See, here what happens is INR has come down to 1.5. I want to take it to 2 to 3. That is going to happen. Not today, Monday. I'm giving it. It's going to happen Wednesday, Tuesday, and Wednesday evening. So
no, at that point, it doesn't act because it is going to take 3 days to act. By the time you want to start the anticoagulation, it starts acting. So that is the reason.
Taken protein C and S inhibition because of the warfarin.
Protein C and S inhibition. That is going to be in the early phase. See, that is the reason why you do the overlap anticoagulation. So I don't think we'll discuss that here. Probably that is the reason why you're talking about the bridging in the post-operative period. I think we'll skip that out at this point. The next case is probably going to be more for a physician at this point. Fracture of the humerus, patient 60-year-old female, stable coronary artery disease, anterior wall ischemia. Patient is on statin, beta blocker, dual antiplatelet therapy, and nicorandil. Had an ACS 1 year ago. You don't have the details. Patient comes into your hospital, comes to the physician for an opinion. Hemoglobin, I forget all those values. You just go ahead and tell me. As a physician, stable coronary artery disease, what do you want to do?
So here again, history taking about, because post ACS 1 year ago, we have no details. Then coming back to hemoglobin, 11.9. Again, this is a fracture humerus.
You can skip that. We did that actually on the orthopedic surgery. So anything else you want to do? You want something else?
ECG is showing anterior T wave inversion. So here we want to know the ischemia status. One echo is required for the LV systolic function, and trop T also may be required, sir, for ongoing ischemia.
So you want to look at cardiac troponins in these group of patients?
Negative. So for trop T negative, madam?
Sir, LV function, sir?
LV function is EF is around 47%.
48%. He's a bad cardiologist. He's giving you all typical bad scenarios. Bad examiner he is.
I'll put this way.
Okay, I have a tougher question for you. Don't worry. This is for her. The dual antiplatelet therapy you already answered, so we will not go into that. Now, suppose this patient, same scenario is there in your case. Now, in the previous case, technically what you do is you look at RCRA. The RCRA score is high. So that will come to the enzyme elevation in the next one. So you have to look at troponin. That's a very important point. When to look at troponin, we'll come to later. Now we'll come to the same scenario, more difficult question for Murli because he's a bad examiner. If it's an acute MI, 1 month post myocardial infarction comes for an elective cholecystectomy. Similar case, similar scenario. And what happens to these cases? Suppose the patient is acute MI, patient had no treatment, post PCI, post CABG, what happens?
3 level. So untreated acute MI, revascularization done with CABG and PCI.
PCI.
Scenarios. Okay. This one thing very simple. You have given a nice thing for me. Elective. The word elective cholecystectomy. It is not a gangrenous thing or emergency. That saves my time. Yeah, I like to avoid surgery. I like to avoid surgery with anything. It depends on what type of treatment you have received. If it is a PCI, I would like to know whether it was a POBA, which is very, very uncommon nowadays, whether it is bare metal stent, second thing, or decorative stent. Go and tell me how long to continue. In an elective thing, if a given time, I would like to defer surgery for variable time without stopping.
So elective surgery. Question 1. I'll go one by one. You answer in one line. No detailed answers. Elective surgery, post myocardial infarction, no revascularization. When do you want to do?
No
revascularization.
I would like to wait for
thrombolized.
I would like to wait for 90 days.
90 days. Waiting for 60 days post myocardial infarction is recommendation. 60 days. Now this slide is actually I picked up and made it myself. Within the first 30 days, whatever you do, whether you have not revascularized or whether you have revascularized with a PCA or a CABG, the mortality is very high. The second one is up to 60 days. Then after that, up to 60 days, the MACE event rate is high. Beyond that, it tapers off. So 60 days is the time for these patients. The post PCI scenario, suppose the patient had a CABG. How long do you want to wait?
Minimum 3 months, maximum.
So stable, if you want an early surgery, the best approach is to do a CABG. Within 30 days, you can take them up. Electively, preferably 60 days, like what he says, post CABG. If you have a PCI, bare metal stent, wait for 1 month, drug-eluting stent, wait for 3 months. It's very, very simple. So if you want earliest surgery, CABG is the best. But if you want to do it very fast, there is a problem like let's say CA or malignancy or something, you can still do one thing. You can do a POBA and get out. Within 14 days of a POBA, you can take the patient for a surgery. It depends on your scenario. At that point, you can start treating these patients. Now, the cardiac enzyme is what you wanted. Now, how often do you check cardiac enzymes postoperatively? Madam wanted a preoperative cardiac enzyme for the patient with stable ischemic heart disease. Postoperatively, do you check?
Postoperatively, I don't check unless there is some signs of cardiac stress like hypotension or chest pain and other patient symptoms. If they have, we used to check. Not routinely, we used to check postoperative enzymes. But what I can do postoperatively is to have a controlled heart rate, have a controlled blood pressure.
So you want to
decrease the LV stress. That is the main thing. Avoid acidosis. Just to check whether there is any acidosis, hypoxia, hypercarbia. These are the things because hypercarbia is common after some infusions like fentanyl.
Let me teach you something new today. There's a new entity called MINS, myocardial injury after non-cardiac surgery. This is a very new terminology created from Mayo Clinic. What happens is within the first 72 hours postoperatively, when the cardiac enzyme troponins are elevated. Now this happens in about 8%, of whom 84% have no symptoms. 35% had only ECG changes. Typical MI definition criteria is taken only by half the patients. So we are looking at postoperative. What is the importance of MINS in these patients is the 30-day mortality is 9.8% compared to those without enzyme elevation. So it's very, very important to look at this. So what do you do? Who is the patient for whom you need to look at this? I'll finish this. So what is the patient? You want to say something? Go ahead. Otherwise, I'll finish the algorithm.
But it's a common thing. In fact, they have reinvented the same thing. To understand, today universal definition of myocardial infarction has become various types. I'm not going to the detailed classification, but type 2 is common postoperative. It is not that regular MI that we come across where you take for primary PCI, mostly it is demand supply mismatch. In fact, the previous talk, nicely talked by Ajit, where you look at the calcification, even such studies, we have available for perioperative things. People who have had multivessel disease, who had a MI postoperatively, when you went into the pathology, the actual plaque was not the plaque, the tighter. That is, for example, I had a LED plaque 80%, RCA 60%. I have had a MI in the OM territory. What it indirectly means is your vascular disease is diffuse. These things are markers. The MI was not under point. It's not that my 80% LED plaque, rather my 40% OM, the plaque, vulnerable plaque rupture and cause. Same thing has been shown in a different way in a milder form by you. That's what I want.
So what we know today is this. This is the 2021 algorithm for assessment. High risk features, patients with age more than 65, 45 to 65 with the history of coronary artery disease, or anybody with an RCRI more than 1. So it's going to be diabetes plus hypertension. Even the first case, what we should have done is, if you have any of these criteria, you have to look at what is called as troponin T and NT-proBNP. Both are prognostic. NT-proBNP being high in the preoperative period is clearly suggestive of a postoperative increase in mortality. It need not be cardiac mortality. It seems to be predicting non-cardiac all-cause mortality also. So in all these patients, today, if you're learning two things, look at RCRI and start looking at troponin T and NT-proBNP in the preoperative phase. You're looking at preoperative assessment. Preoperatively, look at NT-proBNP and troponin. If the troponin is less than 300, there is very low risk of MINS and postoperative events. So if you're looking at NT-proBNP, it is going to be prognostic for you at that point. If it is more than 300, what do? High risk, postoperatively, this is for you, Vijay. Every day you check at troponin T and then look at 48 to 78 hours postoperative ECG. So this is the algorithm today accepted for these patients. So if your preoperative NT-proBNP is elevated, you have to be looking at postoperative MINS. And how do you manage MINS without any ECG changes or without myocardial infarction? If there is MI criteria satisfied, like what Murli says, treat for like an MI. What do you do for those patients where they have asymptomatic elevation? The data is very unclear, but possibly statins and aspirin must be started postoperatively and continue. Probably assess them later. So MINS is a new term which we have to be looking at in future. This is going to be a combination of anesthesia. What is your preference of anesthesia in most of these cardiac patients?
First of all, I want to know why brufen and aspirin both are being given in this case, this particular scenario.
1 year post ACS patient
Are
is
they
on
additive and there are controversial things like brufen and aspirin? Are they additive or they?
Brufen? Brufen was for the
rheumatoid and
Repeat the question.
no, your choice was very simple. Your choice was more for the anesthesia, choice of anesthesia.
For humerus.
For these kind of patients. Do you prefer a general anesthesia, a combination of regional with general anesthesia?
Regional blocks are being given nowadays, but considering the risk factors, if the risk is too high, we prefer giving general anesthesia itself.
What about giving a regional block with IV sedation? What we call as combination anesthesia nowadays.
Ultrasound guided regional block is safe, but considering if there are complications like last, that is local anesthetic.
So what I notice is that most of the times the problem that keeps cropping up is with.
So we think of adverse events. So to prevent all this, and if the patient is on aspirin and clopid together, so we want to avoid, if at all the patient needs surgery immediately. Of course, humerus surgery can be postponed till we can stop clopid and plan with aspirin.
Plan for surgery.
But
you prefer a general anesthesia in these patients. That's what you say. But the point is the newer things they say that you don't have to give for an intubated anesthesia for cardiac patients.
No
basically.
need for intubated anesthesia, but being a regional block with so many drugs.
Because the intubation is not a problem. Extubation is when the problem happens.
So there are many events which are problematic for cardiac patients, sir.
So what about your intraoperative? One small question to Dr. Uma. Are you okay with patient taking ibuprofen preoperatively for rheumatoid arthritis?
Pre-op, okay, sir, but NSAIDs with ACS, I think it is.
Problem with the NSAIDs is they also have antiplatelet effects. They also have decreased the thromboxane. So there is a guidance clearly which says if you're going to give ibuprofen, diclofenac, or diclofenac, you have to ketorolac, you have to stop 1 to 2 days prior to surgery. And if it is a long-acting preparations, 4 days prior to surgery, you have to stop. There is a little bit of guidance on that. What about intraoperative blood pressure? What is your preferred? You already told us that you want to have the preoperative blood pressure. So it is going to be, you try to avoid hypotension or avoid hypertension. What is your choice?
So we want to match myocardial oxygen supply and demand. That is our concern in TROP. There should not be tachycardia, there should not be bradycardia, there should not be hypotension, there should not be hypertension. So we want to maintain around that pre-op BP. That is the concern. We don't want undue fall, exaggerated rise also we don't want. So preemptively we want to control BP. That is maintaining the adequate depth of anesthesia and the making the losses correct and making blood losses. So the main thing is monitoring introp. That is the basic thing. So introp usually nothing happens during, as you said, on extubation when there is a sympathetic surge, undue autonomic surge, sympathoadrenal stimulation that happens during suction and extubation. So there are various drugs which we use.
Murli, about POISE 3, just one word about POISE 3. POISE 3, the avoidance of intraoperative MAP more than 60 or more than 80, both have the same effects. There are two messages that POISE 3 is the study that came up with the perioperative ischemia evaluation in 2022, had two messages. Whether you're trying to have a slightly higher pressure or lower pressure, there is no change in mortality. Second important message is about what the ACE inhibitors and ARBs, they say they are quite safe. So you don't have to worry about it. I think we will skip to this, the anesthesia part. The last case is, I will just give you a gist of what is this. This is going to be a patient with mild breathlessness on exertion, evaluated, who walks 20 minutes daily. The ejection fraction is 30 to 35% for the first time. Comes to the physician, you ordered an echo, 30 to 35% ejection fraction. What do you think you want to do?
This patient is being posted for umbilical hernia. Umbilical hernia
elective surgery.
being sort of EF is less than 30, which is significant reduction in the function of LV. So I will ask for thorough cardiac evaluation before posting the patient.
Doctor,
Because,
agreed. We'll give it to the physician and the cardiologist.
It's not an emergency.
Agreed. So she wants to postpone the surgery. Your idea?
My idea is with ejection fraction of 30 to 35%, is this surgery going to be life-saving?
No.
Otherwise, defer.
Now refer to cardiologist.
Just so you scored RCRA, clearly. So
now, clearly heart failure is more dangerous than coronary artery disease. You must understand, heart failure is much more dangerous than coronary artery disease. The risk involved with heart failure for symptomatic or asymptomatic is much higher. Remember that. Any newly diagnosed heart failure, postpone surgery. I think all three had a very clear mandate. I think all of you should also take. The surgeon pressurize you also don't accept. You wait for at least 3 months, give them good therapy, and then take up for surgery. Otherwise, the risk is very, very high in these group of patients. And we'll forget the risk of the anesthesia in these group of patients. And I think one clear point is, in heart failure, there is no, it is not a contraindication. Risk is more, but the point is you have to give them good therapy and then plan for surgery. It's not like you delay the surgery. So I think since time is very short, I will give a summary of what we have discussed so far. This is the simplest algorithm. We have more or less touched everything. The first question you ask is the surgery emergency surgery? If it's emergency surgery, take a high risk consent, go ahead. Look at the current hemodynamics at that point. Hypotension is more predictive of postoperative problem than the hypertension, point one. Next is you look at the step 2, you try to evaluate and treat these patients according to guideline directed medical therapy for all other patients. Treat them accordingly and then start deciding what is to be done. So what is going to be the next question? Next question is going to be the risk of the surgical procedure. High risk patients, more evaluation. Low risk patients, most of the time on good therapy, you don't need further evaluation, take them up for surgery. Look at the clinical functional capacity like what Dr. Uma had said. And if the clinical functional capacity is more than 4 meds. So what is going to be 4 meds? Anybody who can climb 1 flight of stairs. Simple. If you're going to climb 1 flight of stairs, you are more than 4 meds. You're more or less through for surgery. It's like low risk surgery. But look at RCRA score also. If the RCRA score keeps going up, then you have to be a little more careful with all these patients. Less than 4 meds need further evaluation. So you have to evaluate them. Make sure you're going to be looking at all the factors. And beyond this, there is only one thing. Look at RCRA score for all your patients. RCRA is very important. What is it? Type of surgery, previous history of ischemic heart disease, congestive heart failure, cerebrovascular disease. You may look at diabetes on insulin and preoperative insulin that is more than creatinine that's more than 2. So if there are no risk factors, more problems. And for all your patients, look at this: age more than 65, 45 to 65 with heart disease, RCRA more than 1. Look at NT-proBNP. NT-proBNP is predictive of a problem. If NT-proBNP is normal, you don't need anything. Patient is going to do well most of the time. If it is high, more than 300, post-operatively look at cardiac enzymes and NT-proBNP, and that really TROP especially is useful for the next 48 to 72 hours. And post-operative ECG is beneficial, and this is clearly beneficial and clearly been there. Now, I should specifically thank all the 4 panelists, though I've kept Vijay a little away because of shortage of time. Dr. Murli, Dr. Vijay, Dr. Uma, and Dr. Mala for excellent discussion. Thank you so much. We learned a lot during this. Any questions you want to ask? Probably one question from the floor to the panelists. Parandaman is not there, so I don't think we'll have questions. Don't worry.
Thank you, sir. Thank you. Indeed, it's a brainstorming session. Give them a big round of applause. Thank Dr. Prabhakar and all the panelists. Thank you once again, sir. Thank you. We again come back for the.
Shanmugam, sir, we finish in 50 minutes, like you said.
We do have some exciting session in the post-lunch session. Please come back in the same hall by